Okay, good morning, class. So today we're going to discuss about the management of patients with coronary vascular disorders or coronary artery disease. So, as we all well know, the coronary arteries are the ones supplying the heart with oxygen and nutrients. So, if a person or a patient is suffering from this type of disease, this can pose a risk later on the patient's life, since if these arteries are become or have become occluded later on, the complication of this disease might lead to myocardial infarction. So, what is coronary artery disease? This refers to a variety of pathologic conditions that obstruct oxygenated blood flow through the arteries that supply the heart. So, like what I've said earlier, the coronary arteries, once they are obstructed by plaques, they can diminish the supply of oxygenated blood. And this is the most prevalent type of cardiovascular disease. And this is one of the leading causes of morbidity and mortality here in the Philippines. Not only in the Philippines, but all over the world, since CAD is very, very common among people. So as you can see here, these are the arterial wall layers. We have the tunica intima, the media, which contains the smooth muscles, and the tunica adventitia, which is the outermost layer of the arteries. So arteriosclerosis. In arteriosclerosis, to differentiate it from atherosclerosis, this is a diffuse process whereby the muscle fibers, so the smooth muscles, of the arteries and the endothelial lining of the walls of the arteries and the arterioles become thickened. In short, there's hardening of the arteries. So there's stiffness of the arteries. If there's stiffness of the arteries, what happens here is the blood flow or the arteries become constricted and the blood flow will be diminished. And arteriosclerosis is commonly occurring in patients who have been chronic smokers. That's what arteriosclerosis is. But for atherosclerosis, it is a progressive and reversible and atherosclerosis affecting the intimal layers of the coronary artery. So intimal layers, the innermost layer, the tunica intima, is the one that is affected in atherosclerosis. What are the risk factors? We have two, the non-modifiable and the modifiable one. When we talk about non-modifiable, it means that you cannot change it. Can it change? It's there. Like family history of CAD. If you have an immediate family member, your parents, grandparents who have suffered from this, it's a risk factor for you as well. Increasing age, because as we all well know, as we grow older, most of the body functioning will deteriorate. They decrease in function. That includes our blood vessels. Gender. Unfortunately, for us males, we develop CAD at an earlier stage or at a younger age than that of women. So males are more susceptible in developing CADs. Race. This is higher amongst African Americans or those who are from Africa as well, blacks. So race is also a non-modifiable factor here. Although this is commonly occurring among all races, but higher incidences have been found in African Americans. Now we go to the modifiable risk factors, meaning we can change this. If you have hyperlipidemia, meaning you have an increased lipids in the blood, we can turn that around by doing proper dieting. So avoidance of any fast food, any fatty foods in order to lower down our blood lipid levels. Cigarette smoking. So if we cease to do cigarette smoking, this will decrease the risk of the development of CADs. Like what I've said, arteriosclerosis or smoking is one of the risks or one of the factors of developing arteriosclerosis. Next would be hypertension. With proper diet and also proper medications for hypertension, we can reverse the risk for it. For those who have diabetes, especially type 2, with proper insulin therapy or oral hypoglycemics, they can reverse the risk as well. Those who have metabolic syndrome. What is metabolic syndrome? These are people who have a large abdominal girth. You can see that their arms and legs are skinny, but when it comes to the center, the torso, most specifically the abs, or not really abs, the flabs, this is metabolic syndrome, wherein there is central obesity. When it says central obesity, the abdominal area is large. Why? The fatty deposits, the adipose tissue is increased amount in that area, in the abdomen. And that can be a risk factor as well for the development of CADs. Most especially if that person or patient has large amount of visceral fat. So to turn that around, you need to do proper diet again and exercise. Obesity as well, since if you are obese, you have, of course, most likely you have increased lipids in your blood as well. So again, proper diet and exercise is going to be done by this patient. And physical inactivity, those who live a sedentary life, wherein there's no exercise at all they want to do is eat and sleep or rest for the whole day while watching TV. This is also a risk factor in the development of CAD. So again, we need to teach patients how important exercise is. Pathophysiology of this disease. So there will be accumulation of lipids or fatty streaks in the intima of the coronary artery. So that's the innermost layer of our arteries. Most especially if you're fond of eating foods that are high in fats, like fast food. If you're always eating at McDonald's or Jollibee or KFC and other fast food, or you're really fond of eating fried foods, this can happen. And if they accumulate there, macrophages will detect them as foreign and it will or they will ingest the lipids and die. And the proliferation of smooth muscle cells will form a fibrous cap on those dead macrophages. And this will now lead to the development of atheroma. When we say atheroma, that is the fibrous plaque that has been formed, brought about by the dying macrophages, the proliferation of smooth muscle cells over them, wherein that once that atheroma is formed or that fibrous plaque is formed, it can pose a risk later on the patient's life. And once that happens, once that atheroma is formed there will be degenerative changes in the arterial wall. Of course, once that is formed, it will narrow the lumen of the artery. So it will restrict blood flow now. It somehow obstructs the lumen of the artery. So how is blood going to pass through if that plaque is there? It's growing there in the innermost layer of the arteries. Therefore, there will be increased resistance to blood flow. And if that happens, thrombus formation may occur, which is very, very dangerous. So, if there is narrowing of the lumen, there will be a decrease in the blood flow to the myocardium. And there will be myocardial ischemia, meaning there is limited blood supply to the muscles of the heart, leading now to angina pectoris. That will be the subject of our next topic later on, wherein the patient will experience chest pains every now and then. There are different types of angina, but yes, this is the end result of having a coronary artery disease, because once blood flow is limited to the myocardium, pain is going to be felt by the patient. And if it complicates, that can later on lead to myocardial infarction, most especially if that thrombus formation becomes an embolus. And if that embolus floats in the blood, it will eventually reach the smaller parts of the coronary arteries, blocking it. Of course, once the artery is blocked, blood flow will be obstructed, leading now to MI, or myocardial infarction. The heart will stop working once that happens, because there's no delivery of oxygen happening since the artery has been obstructed. Clinical manifestations: angina is a classic sign of CAD, chest pains. Most especially, it's originating, take note, the chest pain for angina is originating at the left side of the chest, and it may radiate to the left shoulder, jaw, left arm. Nausea and vomiting can be felt by the patient. Fainting can occur, diaphoresis or excessive sweating, and cool extremities. And there can be sudden cardiac death. So that's already MI. There will be necrosis of the cardiac tissue if MI happens. Laboratory diagnostics. In ECGs, arrhythmias will be detected. And if you recall our lesson regarding the ECG, the PQR-ST, there's a T wave depression or ST segment depression. And during coronary angiography, take note again of our nursing responsibility here. Before the patient will be having this diagnostic procedure, they need to be assessed for allergies in seafood, because a radiopaque dye, which is iodine, will be injected into the patient to visualize the coronary arteries. So this will determine the location and the extent of narrowing. Stress test will also be done, treadmill or over a stationary bicycle, and the stress test may provoke a chest pain. So this is an example of a coronary angiography, and it can be seen here, the obstruction. You see that faint portion here, that's the obstructed part of the coronary artery. So here, another example, great example would be here. There's obstruction seen in the coronary artery here. So this is an old type of ECG. So here for ECG monitoring during the stress test. Medical management. Our goals would be to decrease myocardial oxygen demand or cardiac workload and increase oxygen supply to the myocardium. And of course, since pain is felt by the patient, we need to alleviate chest pain as well. Now, control of risk factors. We have the drug therapy. We are going to give vasodilators to patients. Examples of a great example of vasodilator that can be given to patients would be nitroglycerin. We'll talk more about nitroglycerin once we are already in the topic of angina and MI. Anticoagulants such as aspirin can be given. So some others, they can be given heparin or warfarin in order to prevent the occurrence of thrombus formation. That is what we are avoiding here. That's why patients are given anticoagulants. And if the patient's lipid profile is increased, so the lipid levels in the blood is increased, we are going to give antilipidemics. These are drugs that usually end in statin, like atorvastatin. Antihypertensives will also be given, such as beta blockers. We all well know that beta blockers, the suffix always end in alol. Calcium channel blockers, the suffix always end in dipin, like amlodipine, nifedipine. And thrombolytics, if the patient is already suffering from myocardial infarction, thrombolytics will already be given to this patient, like alteplase or retaplase. They always end in teplase. Now, this is what we need to teach to patients who are suffering from coronary artery disease or those who have risk factors for coronary artery disease. The nutrient content of the therapeutic lifestyle changes diet. Total calories should have a balanced intake and expenditure to maintain the desirable weight. So the total calories depend on the weight of the patient. We need to figure out the BMI as well in order to know how much calories that the patient should take per day. And not only the weight is taken into account here, even the activity level per day of the patient should be asked by us nurses in order to determine the total calorie intake that the patient is going to need per day. You can find online calorie calculators. You can figure that out yourselves on your own. These online calorie calculators will give you an insight on how much calories that you need to take per day, because you're going to enter there your weight, your height, and the level of activity that you are doing every day. If you have a sedentary lifestyle, that calculator is also going to ask you that. If you have a very athletic lifestyle, very active lifestyle, you need to input it there as well. Total fat should only be around 25 to 35% of calories, and polyunsaturated fat should be up to around 10% of total calories. Monounsaturated fat up to 20% of total calories. Carbs should be at around 50 to 60% of calories. So if you have an average daily caloric intake of 2,000 calories, 1,000 of that should be from carbohydrates. Dietary fiber as well. It should be around 20 to 30 grams per day, because dietary fiber will also help lower down the low density lipoproteins, or the bad cholesterol levels that we have in our body. Protein should be approximately around 15% of total calories, and cholesterol should be below 200 milligrams per day. So it shouldn't be more than that. So we have the antilipidemic agents, the HMG-CoA reductase inhibitors. Because this HMG-CoA reductase, this is an enzyme involved in the lipid synthesis, or the methylglutarate coenzyme A, or 3-hydroxy-3-methylglutarate coenzyme A. This enzyme is needed for lipid synthesis. So we have the following: statins, atorvastatin, Lipitor or simvastatin, Zocor. Take note, when we are giving this to patients, they may experience muscle pains or muscle aches and joint pains. So myalgia, muscle pain, or arthralgia, joint pains may be felt. These are common adverse effects of these medications. And we need to monitor the liver function tests as well, the AST and the ALT of the patient, because this can be toxic to the liver. Fibric acid or the fibrates, these increase high density lipoproteins and decrease triglycerides. Remember, HDLs are good cholesterol. High density, high heaven, good, low hell, bad cholesterol. Examples of fibric acids would be fenofibrate, tricor, and gemfibrozil or lopid. But if the patient is suffering from, let's say, renal disorders such as chronic renal failure or acute renal failure or any liver disease like liver cirrhosis, these drugs are contraindicated to patients who has them. So do not give these drugs. Bile acid sequestrants, they significantly decrease the bad cholesterol, the LDLs, and increase the good cholesterol, the HDLs. So examples of these is or are cholestyramine, questran, and cholestyramine cholestid. They oxidize cholesterol into bile acids, which lower fat absorption. And take note, this should be taken before meals. Bile acid sequestrants should be taken before meals. We should advise our patients this. Cholesterol absorption inhibitors. They decrease the bad cholesterol, the LDLs, and inhibits the absorption of cholesterol in the small intestines, like ezetimibe or Zetia. It's used in combination with the statins. Again, this is contraindicated to patients who have a liver disease. Omega-3 ethyl esters or fish oil capsules. They lower triglycerides by inhibiting TG production in the liver or triglyceride production in the liver, and they can be used with statins. If you have been watching advertisements about fish like tuna that contains omega-3, it's good for the heart. This is the reason behind it, because they lower triglyceride levels. Surgeries. Surgeries can be done if the worst thing has happened to the patient, like MI. We first have CABG or coronary artery bypass graft, or we call it as CABG. We also have the percutaneous transluminal coronary angioplasty, PTCA, or coronary artery stenting and laser angioplasty. And what are these type of surgeries? We start with the coronary artery bypass graft. So what happens here in the coronary artery bypass graft is that this is an open heart surgery. And here in the bypass graft, the surgeon, the heart surgeon, or the cardiothoracic surgeon is going to get another blood vessel from the patient's body. And the common site would be at the leg. Surgeon is going to get this blood vessel from the leg, the small saphenous vein, as you can see here in the illustration, and will attempt to connect the left subclavian artery into the portion of the artery, coronary artery, the distal portion of the coronary artery that has been blocked. As you can see here in the illustration, there is a blockage. So in order to bypass, that's why it's known as bypass graft. It is going to bypass the blockages that you can see here. So as you can see, these blood vessels that came from the other parts of the body, they are attached to the distal portions of the arteries in order to supply the heart with oxygenated blood. They are somehow connected to the aorta. As you can see here, one is connected into the aortic arch. The other is connected into the left subclavian artery, and they are bypassing the blockages that you can see here in this illustration. My grandparents on the mother's side, from the mother's side, had these types of surgery. This is known as cabbage. So this will improve the oxygenation of the heart if the coronary arteries are blocked. This is now the stent that I have mentioned earlier, coronary artery stenting. So this is done through what do you call this? This is done by inserting a catheter through cardiac catheterization into the femoral arteries. And they are going to insert this catheter into that portion where there is a blockage. Of course, doctors who are going to do this need to visualize this with a radiopaque dye in order to check which part of the coronary artery is obstructed. And once they find the obstruction, they will place this catheter there with a balloon and inflate the balloon. Once the balloon is inflated, the stent will be the one to do the scraping. It will scrape that plaque that has formed and take it away once the surgeon has removed it, or once the doctor has removed this catheter. So once that stent is in place, the constricted artery or the occluded artery becomes dilated again, and blood flow is now increased to the area of the heart that has been, or that has an obstruction brought about by these plaques. And we have the percutaneous transluminal coronary angioplasty. So the PTCA is quite similar to coronary artery stenting. However, there's no stent that is placed there. The balloon tipped catheter through cardiac catheterization is just going to compress the plaque, further increasing the lumen of the constricted artery. So that's how PTCA is done. So it's similar, but a stent is not left in place, unlike that of coronary artery stenting. And lastly, for the laser angioplasty, the laser here, it's again done through cardiac catheterization. The laser tip catheter will be forwarded into that part of the coronary artery that has the plaque. Of course, visualization again is important here in this procedure, and that laser will vaporize the plaques in order to improve the blood flow into that constricted or obstructed artery. So that's how laser angioplasty is done. So there. Nursing management. We initiate primary and secondary prevention. If there are any risk factors, such as modifiable or non-modifiable ones, we are going to advise patients to modify their lifestyle, their diet, and of course, practice doing daily exercises. That should be at around 30 minutes per day. 30 minutes of aerobic exercise won't hurt. And it can sometimes be fun because there are a lot of YouTube exercises nowadays that patients can choose from. Dance exercise such as Zumba or Taibo or whatsoever. By doing 30 minutes of exercise per day, this will help lower down the risk for the development of coronary artery disease. Of course, they should also avoid eating food that is rich in fats, especially saturated fat. So they should avoid eating fast food or fried foods. Prevention and control risk factors. That's what I have mentioned. And if you're already 30 and above, it is mandatory for you to have your lipid profile checked, since it is common for patients or people who are 30 and above to have an increased blood cholesterol levels. So that you know what to do if you found out that you have an increased total cholesterol. If it's more than 200 milligrams per deciliter, you need to do measures in order to lower it down less than 200. Stop using tobacco as well. You need to cease cigarette smoking. Control of hypertension and diabetes mellitus should be needed as well. Weight reduction by doing daily exercises, like what I've mentioned, 30 minutes. Diet modification, increased fiber in the diet will help reduce cholesterol levels in the body. Exercise programs can be done. Like what I've said, it's very, or if you have internet at home, it's very, very accessible nowadays to do home exercises. And of course, stress reduction techniques, because stress can also contribute to the development of coronary artery disease. So if you have a stressful work, stressful life, you need to do stress reduction techniques by doing yoga, by doing guided imagery. Massage can also help reduce stress. So we need to teach our patients these things in order to avoid the development of CAD. So that's it for coronary artery disease. We will be discussing further um, the topic on angina and myocardial infarction. So if you have any questions about our topic regarding coronary artery disease, again, please do not hesitate to send me a message and I will answer these questions for you. And also a reminder, do supplemental reading from your books, your Brunner and Siddharth books regarding this topic. So read all about coronary artery disease, angina, and myocardial infarction from your MS books. Again, that's it for today's topic. Thank you very much for listening and have a great day, everyone.